Hi everyone, I want to start by expressing my gratitude to Dr. Evangelista and Aorta Hub for the chance to discuss this clinical case we have named hemolytic anemia post-aortic dissection that is rare but manageable. I am Francisco Calvo, from Vigo. I'm a cardiologist with a focus on cardiac imaging, valvular pathologies and aortic conditions, and I am lucky to be employed at this wonderful hospital. The case presented today is that of a 43-year-old man who came to emergency department of our hospital in March 2023 due to a stabbing chest pain with presyncope and dyspnea. Among his medical history, the only notable point was allergy to beta-lactanic. He was a former smoker, and he had no known hypertension or other cardiovascular risk factors. And there were no family histories of heart disease or sudden death, plus he was experiencing high levels of work stress. Following the initial evaluation in the emergency room, a limited echocardiogram was conducted, revealing a flap in the aortic root, and severe aortic insufficiency was noted. Subsequently, an angiogram was performed, which demonstrated a type A dissection extending to the abdominal aorta. Without data of poor perfusion and already in the operating room, an intraoperative echocardiogram was performed that demonstrated the presence of an entry tear in the root. Consequently, the diagnosis of type A aortic dissection was confirmed, TAE1M0, as per the latest M classification. In an emergency management, surgical treatment was indicated. The patient underwent surgery and a Bentall procedure involving a 25 mm mechanical valve tube and the reimplantation of both coronary ostia. Days later, while hospitalized, a left subclavian carotid bypass with terminal lateral anastomosis was initially carried out. Then, 24 hours later, a second procedure was conducted, with implantation of a hybrid endoprosthesis Evita open neotrifurcate. This endoprosthesis, as shown in the diagram, consists of a proximal graft of Dacron, which in this case was 26 mm, and a nitinol stent that is covered, which has a total length of 175 mm in our case. The trifurcated version, which we used on this occasion, has an anastomosis for the reimplantation of the three supra-aortic trunks, as you can see in this figure. And in the animation, we see different procedure steps of the intervention. The whole process is conducted with the aid of guides, and it was proceed to a controlled release of the covered stent. This is the final arch position, and subsequently sutures are performed. In this case, this prosthesis also has a special skirt for continuous suturing, distal and proximal sutures. This is the final result after the reimplantation of the supra-aortic trunks, which in our case was. 6 months later, the patient is seen in consultation and continued complaining of poor recovery. Specifically, he reported experiencing effort-related dyspnea and quite bothersome tinnitus, having very poor blood pressure control, with marked asymmetry of the arterial pulse between both arms, and he also presented bilateral intermittent leg claudication, sexual dysfunction, which all contributed to a depressive syndrome. At that moment, besides the anticoagulant for his mechanical prosthesis, he required as many as 4 medications to adequately control his blood pressure. Ferrous sulfate for the treatment of anemia, and likewise various psychotropic medications for the management of his depression. At that time, we analyzed all tests available, a number of additional tests that we will comment on shortly. As etiological study of the patient aortic disease, an NGS panel of the aorta had been performed, showing the presence of 3 mutations in genes related to aortic pathology, but they were all variant of uncertain significance. On the other hand, we had an echocardiogram available that demonstrated that the left ventricular function was normal and that the prosthesis was functioning properly, and finally, the aortic CT showed a good result from the surgery performed, with a residual uncomplicated dissection persisting in the descending aorta up to the renal arteries. Let's proceed with the physical examination of the patient already in the consultation. He was a tall man with little suspicion of syndromic disease. What was notable in the body inspection was his skin and mucosal pallor. A significant pressure symmetry between both arms, with the right arm's pressure nearly 40 millimeters higher than that of the left arm. The examination at the aortic site did not indicate any dysfunction of the prosthesis. Conversely, it was notable that a significant thrill could be felt in the right supraclavicular area. At the same time, a loud systolic murmur was auscultated. A blood test study was conducted, highlighting first the significant alterations in the hemogram. The results of hemogram showed very low hemoglobin and hematocrit levels, along with microcytosis evidenced by low mean corpuscular volume and mean corpuscular hemoglobin. The iron kinetics, on the other hand, demonstrated iron deficiency and also signs of hemolysis with very high LDH values, 1320 units per liter, with undetectable haptoglobin and schistocytes in peripheral blood. This means that the patient had ongoing intravascular hemolytic anemia along with iron deficiency. We then performed a new transthoracic echocardiogram, which essentially showed no significant changes compared to the previous one. Left ventricular function was normal, with no new valvular pathologies detected, and there was no information regarding prosthetic dysfunction, as the transprosthetic velocities measured via both the apical window and the right parasternal window were within the normal limits. During the same procedure, an exploration was conducted via the suprasternal window, which first showed us, as indicated by the arrow, a very turbulent flow in the proximal aortic arch near the trifurcation's emergence, and that using continuous Doppler, it achieved a speed of nearly 5 meters per second, which was approximately double the transvalvular speed we had recorded via the right parasternal window. We conducted a new angio-CT synchronized during diastole, as indicated by the discs of the mechanical valve prosthesis, which revealed the existence of folds and kinks in the aortic arch. In particular, these folds were probably more noticeable at the transition between the dacron and the stent graft of the hybrid endoprosthesis, as illustrated by the multiplanar images, but they were also present at the junction between the dacron of the ventral and the dacron of the hybrid endoprosthesis. Afterwards, we also reviewed the previous studies, and these changes, although less striking, were already evident. The previous findings were sufficient to establish a well-founded suspicion of severe stenosis of the aortic arch graft, and thus indicate treatments, and we proceeded directly to an invasive angiography. We placed a pigtail catheter through the right radial access into the ascending neo-aorta, showing, as the arrow indicates, a marked stenosis of the graft, and secondly, by advancing a second catheter through the femoral root, we obtained a very significant difference in versions, showing an average gradient exceeding 60 millimeters of mercury, which matched perfectly with the Doppler echocardiogram results. Next, we carried out the percutaneous treatment for the stenosis, showing some important images and steps. On one hand, through a left femoral access, we performed balloon angioplasty with 3 inflations. Next, with the right femoral access, a CP stent was crimped onto a 24 millimeter balloon that could not cross the stenosis. A VAT technique was conducted with assistance on the balloon that had been previously inserted. And at last we did an angiographic check through the right radial rote. The angiogram still revealed the existence of a clear stent indentation. The simultaneous pressure recording showed a complete disappearance of the high gradients across the stent. That is to say, we could define the outcome as excellent. After the procedure, our patient recovered swiftly, and it's important to note the rapid and significant clinical improvement, especially in the improvement and reduction of tinnitus and in better blood pressure control, requiring a rapid decrease in medications because of hypotension with his regular treatment. Betterment of bilateral intermittent claudication, which was also seen in lab parameters with hemoglobin levels in the blood test returning to normal, LDH and haptoglobin levels. This improvement was also evident in non-invasive tests. However, turbulent flow continued in the prosthetic tube via the suprasternal window. With continuous Doppler, the maximum speed we recorded did not reach 3 meters per second, and it is worth noting that the previous speed was 5 meters per second. In other words, there was a very evident improvement. To clarify this unusual case and his evolution, I will provide a brief literature review on aortic arch surgery and the occurrence of kinking and stenosis. There are very few studies available, and those that exist are not very comprehensive. Some published studies report only a handful of cases. The largest study consists of 167 cases. In this series, kinking and stenosis are reported in between 0 and 5% of patients. This means it appears to be a rare complication. Several factors are proposed for the kinking or bending of the grafts. Perhaps the most important is excessive graft length. For the surgeon, it is a significant technical challenge to accurately measure graft length with an empty heart, the clamped aorta, and an anatomy that can change dramatically when circulation and blood pressure is restored. The second important factor is likely the anatomical angle of the arch. Certain arch anatomies present significant challenges and can promote this bending. Additionally, other factors like these are taken into account, such as distorted blood flow patterns that might arise with mechanical prosthetics or bicuspid valves, along with alterations in the heart's anatomy, in the position and the surrounding tissues that could emerge with the evolution of post-cardiac surgery. But kinking isn't just a phenomenon like this. Complications such as heart failure, thromboembolism, or hemolysis have been noted, as in our case. Concerning our complication, the intravascular hemolytic anemia linked to aortic surgery, the data available remains quite rare. In the year 2023, Davison released a case report and conducted a review of the literature published until then, encompassing 30 cases. Most cases were associated with graft stenosis, or primarily with kinking, as you can see. Most cases also originated from Eastern series, particularly Japanese ones. And these events took place at different times following aortic surgery, with many also linked to dissections. Since Davison's publication until now, approximately 10 cases have been added, meaning we currently have about 40 published cases on this topic. As a final message, we believe our case can lead to the following conclusions. Firstly, intravascular hemolytic anemia is an uncommon complication for patients who have undergone aortic dissection surgery. First a Bentall surgery and then an aortic arch surgery. In the second place, the importance of ruling out the usual suspect, mechanical prosthesis dysfunction, as it was the case in our situation. Thirdly, we wanted to emphasize the relevance of the physical examination findings, the palpation of a thrill in a vascular pathway that should always raise suspicion of turbulent flow. Certainly, imaging techniques provided us with proper guidance in this case, including the CT scan demonstrating the anatomical bend and particularly the Doppler, which revealed a significant increase in velocities in the region of the thrill. Without a doubt, angiography has played a crucial role in both the final diagnosis, as the images illustrate, and in the successful treatment. Finally, it is worth noting that while this complication is rare, there have only been 40 documented cases in the literature. It is possible that with the growing prevalence of aortic arch surgery, we might witness an increase in these complications in the years ahead, hence our decision to present this case. We wish to present this case. And that's all. I deeply appreciate your attention. Thank you very much.